Good afternoon, everybody. Welcome to today's meeting of the Integration Joint Board. I'm Brian Jones, Chair of the Integration Board. Can I please introduce Councillor Colin Stewart, Vice Chair, Jackie Pepper, Chief Officer, Donna Mitchell, Chief Finance Officer, Jess Guild, Clerk to the Board, and Scott Hendry, Democratic Services Manager. And I ask the Clerk to confirm any apologies received, please.
Thank you, Chair. We have apologies today from Sam Riddle and Keith Russell, nurse representative, with Sarah Kettles in his place.
Can I remind those joining us online to use the chat box to attract my attention during the meeting? Thank you. We'll move to 1.1, the membership update. Can I ask the Clerk to confirm the membership update, please?
Thank you, Chair. We have Dave Henderson to be reappointed as the Independent Sector Representative.
Thank you. Point 3, minutes of the previous meeting. Oh, sorry, declarations of interest. So only my second meeting, so bear with me. Any declarations of interest, please? No. Thank you. Point 3, minute of previous meeting. Can we agree the minute from our last meeting held on the 8th of October? Yep. Thank you. Action points update. Any points to address?
Just to say that the action has been completed with the joint development session with Angus Dundee and Perth and Kinross IJBs on the two topics of the out of hours reform and the model of care for general adult mental health. So that's concluded.
Thank you. Lindsay, please.
Good afternoon. Sorry, it's just in regards to the minutes. I was actually, if you could put my name down as an apology, because I was on holiday, but my name isn't on the minute, just so you're.
Thank you. We'll do that. Thank you. Point 5, matters arising. Are there any matters arising from the minute or the action points update? Number 6, we've moved the agenda around. Oops. Sandra?
Thank you. So I've had a question linked to the mental health and learning disability update situation. I am looking for some guidance as to where, so I'm aware that there are private papers that are coming for discussion towards the end of today's meeting, but I'm looking for some information as to where our responsibilities sit as an IJB, with taking into account the where, for example, we will get the opportunity at an IJB before considering such things as the private papers to discuss important publications such as the Auditor General's report regarding mental health and learning disability in Tayside, which made some serious recommendations, which we as an IJB haven't had the opportunity to talk about or discuss or look at taking forward. Other issues such as I'm aware that there was a Mental Welfare Commission visit to Strathmartin Hospital, which myself and public partner colleagues are trying to arrange a visit to, and that's proving problematic. So I'm concerned as service users who are expected to be able to input appropriately to the business of the IJB, just where we avail ourselves of the appropriate information to be able to do that. Thank you, Chair.
Thanks, Sandra. I'm going to pass over to the Chief Officer.
Sandra, I'll address the first point in your question, which relates to the Auditor General's report on mental health and learning disability services, and their report as part of the audit into NHS Tayside. I'm aware that there is an update report being considered by NHS Tayside Board when it meets tomorrow, and it would be my intention following that to provide a full briefing to the Perth and Kinross IJB, but we need to allow NHS Tayside Board to consider that update and its response to the recommendations and the update that's going to be given tomorrow. Thank you.
Thank you, Jackie.
Thank you, Jackie. Would it be appropriate for us as an IJB to invite the Auditor General to come and present to the IJB, so that we had an opportunity to hear firsthand? I'm aware that some of his comments reflected on the governance and the reporting structures of groups that were set up following David Strang's report, which were described as unclear. And yeah, so would that be a reasonable way forward to invite him to come and speak to the IJB?
Chief Officer.
I don't think I've ever been asked a question like that, Sandra, but I think we would need to take some guidance on that in terms of the role of the IJB and its responsibilities vis-a-vis the role of NHS Tayside and its responsibilities and the process that's currently underway. So I'm not sure I can answer that question without seeking quite considerable advice from a variety of different sources.
Okay, so just to be clear, I'm concerned that we as a board are asking to review documentation and make decisions when we're not in full possession of all the information, the appropriate information to do that. So that's my concern, Jackie. Thank you.
Chief Officer.
I think, Sandra, if you're referencing the private paper, then I'm happy to take questions around the appropriate information at that point, but I wouldn't be able to answer that here. Thank you.
Thank you. Thank you. Moving on, point 6, delivering on strategic objectives. We've had to amend the agendas just slightly, so we're going to take the Tayside GP out of our service framework at this point. Can I ask Jill Galloway, please, Angus Health and Social Care Partnership Chief Officer, to introduce the report?
Thank you, Chair, and thank you to everybody for accommodating us early on in your agenda, and that will allow us to move into our the Angus IJB, which is also starting shortly. I'm also joined today by Dr. Scott Jamieson, who is one of our Associate Medical Directors in Angus Health and Social Care Partnership, and Lisa Prudhomme, Head of Community Health and Care Services, both of whom have had a leadership role in this work and been supported by the wider team and stakeholders. So members will have had the paper and the associated documents, so I'm not going to go through them in detail. Chair, the paper comes forward to the IJB as a follow-on from the joint development session held with colleagues across Tayside, where we explored the emerging strategic direction for the GP out of our service and reflected collectively on the system challenges, the learning from the tests of changes that have been undertaken within the service, and the opportunities for whole system reform in relation to out of hours. As members will be aware, Angus IJB holds the lead partner responsibility for strategic coordination and the operational responsibility for the GP out of hours service on behalf of Tayside, and this strategic framework has been developed collaboratively with Dundee and Perth and Kinross Health and Social Care Partnerships and other key stakeholders, including NHS 24, Scottish Ambulance Service, as well as engagement with our public and public partners to help inform the direction of travel. In line with all the integration schemes, all 3 IJBs are required to consider and approve the strategic direction to ensure consistency, alignment and shared ownership across the region. So the framework today that's presented today sets out a clear evidence-based direction for the next decade, shaped by extensive engagement and feedback, not just from our development sessions with IGB members, but with the wider public as well. And there is a statement of engagement that is included within the papers to describe the engagement undertaken to date. So the paper seeks approval from Perth and Kinross Integration Joint Board to formally adopt a strategic framework and to support the direction to NHS Tayside from Angus IGB, enabling the next phase of work. And that will be developing a detailed co-designed service model options through a structured and transparent appraisal process. The strategic framework was approved by Dundee IGB on Wednesday the 10th of December, and just to note for members' awareness, the framework has also been endorsed by GP Sub, and it will be considered later on this afternoon by Angus IGB. So happy to take any questions or reflections before the board is invited to consider the recommendations, Chair. Thank you.
Thank you. Thank you, Jill. Any questions from the board on this paper? No? Oh, yep, Councillor.
Just for clarification, I agree with agreeing the strategic part of this, but I find it concerning as well that we're being asked to agree to this without knowing what the implications to do with the out of our service is going to be for Perth and Kinross. I know that with it out there on the streets, people are worried that the out of our service gets removed from Perth PRI as it is. What guarantee do we know, do we have that that's not actually going to take place?
So in terms of the work that will be taken forward after all three integration joint boards, and hopefully the approval of all three, is to continue the work that we've been doing to co-design and co-develop the options around what potential options there are available to deliver the out of our service. I'm not sure if you were at the development session, but what we highlighted the principles that we were keeping at the heart of why the out of hours reform needed to happen and it mattered, and those principles are included in the future engagement that we will do. I can't sit here and say I can't guarantee what will be provided in every single locality area, but what we can commit to doing is providing the best possible, most efficient and effective service that meets the needs of the population across Tayside. And we have to take into consideration the financial position, and we also need to take into consideration the direction of travel in each of the three local authority areas in line with the IGB strategic commissioning plans. So hopefully that picks up on your question and commitment. And I don't know if Jackie wants to come in as Chief Officer of P&K just in relation to the engagement and the involvement of P&K Health and Social Care Partnership colleagues and the wider support around the piece of work.
Thank you.
Thanks, Jill. I'm just happy to confirm that we've got representation from Perth and Kinross involved in this work, ensuring that the detailed understanding and knowledge and the of the local complexity for Perth and Kinross and the local population needs are going to be taken into account through that. It would be very difficult for Jill to apply that as Chief Officer of Angus, so we need to supply that into the process. And I'm looking at my primary care colleagues here who are nodding in agreement. And I know your time is tight, Jill, but one of the things that I was going to say in my strategic update was to indicate to the IGB that we are taking forward a test of change. And I know that Hamish and Sal may, or Dr. Peterson and Dr. Dougal may be able to say a few words about that rather than myself, because that will also give a great deal of learning about what will work for our population here in Perth City, where we've got quite a high level of the demand coming through. And maybe I know Jill's time is tight, but maybe at the strategic update we can spend a little time on that, Councillor Brampton.
Thank you, Chief Officer. Any other questions? Councillor Illingworth.
Thank you. What are the rough timescales?
So that we were aiming to have a preferred option by April 2026. We've been working extremely closely with Health Improvement Scotland in relation to the engagement part of this, and due to a change within Health Improvement Scotland in relation to how we consult and engage, it may be delayed a further month, so potentially into June. But as we work through the options, then we will have a clearer idea of the timescales, and obviously Jackie will be, as Chief Officer, kept informed of that, so able to provide any update to the IGB in relation to timescales. But we were aiming for an April implementation date to commence.
Thank you. Any other questions? Heather?
Thanks very much for the report, and I think it's quite clear. I suppose just following up on Councillor Illingworth's comments there, it seems quite tight, the timeline that you're outlining when you look at the next phase and what's expected to be included in the next phase, Jill. I'm just wondering how realistic that is, because when you're thinking about, you know, developing the service models, which I know is ongoing, and learning from the test of change, and then looking at the option appraisals, it seems there's quite a lot to do by April, particularly when you've also got to think about the legal aspect and the quality impact assessment. So I'm just asking, is this realistic for that date?
Yeah, thanks Heather. So I guess in terms of the April date was for the approval of the actual model, and we would commence the implementation potentially from April. So it wouldn't be fully implemented. We would have to take a phased approach, but it completely depends on what the preferred model is. So I can't give it. I would ask, we are aspiring to April for the model of care being approved based on the options appraisal work.
So just, sorry, could I come back on that? So just to be clear then, what we're really saying by April is under section 4 next steps that we'll be doing potentially number 1, 2 and 3 rather than the whole
by April.
By
Yeah.
April, rather than the other part of it. Then the implementation plan with the milestones will come later. Okay,
Yeah.
thanks for that clarification. Thank you.
Thank you. Any other questions? No? Okay, thank you. Can we agree the recommendations in the report? Yep. Thank you. Thank you, Jill. Thank you.
Thank you.
Then we'll move on to the Chief Officer's strategic update. Can I ask Jackie to give her verbal update, please?
Thank you very much, Chair. I'm going to address four areas, and then I think I'll invite Dr. Dougal and Dr. Peterson to say a little about the test of change, because I think that's relevant to the discussion that we've just had in terms of what that might mean for learning for us here in Perth and Kinross. My first update relates to a number of developments that have taken place since we last met on the 8th of October, a number of which are contained within reports that are on the agenda around the decision making of Perth and Kinross Council to support the IJB's financial pressure in year to the end of March, but also to update IJB formally that last week on the 10th of December in this very room, a motion was carried to declare a health and social care emergency in Perth and Kinross, and the elected members were expressing a depth of concern about the funding position for the health and social care in Perth and Kinross, and a recognition of there being a structural funding gap for the IJB and the growing pressure on services. But it's also fair to say that in that context, there was a great deal of acknowledgement and appreciation for the staff who are delivering our services daily and overnight, 24/7, 365, and the great work that they do. So I just to emphasise that was also commended across the chamber in terms of the recognition of their support for our most vulnerable people here in Perth and Kinross. It's important to recognise that in that debate and discussion and outcome there, that there was a recognition that we need to work urgently and closely together across the IJB's financial teams and in our budget setting process for both the IJB and across the council and NHST side to take whatever required steps that we need to take. So I just want to keep you updated on that. The council's meetings are available online through YouTube, and if anybody wants to have a link to that, I can send them to you. And the second element of that was to call upon COSLA and Scottish Government and NHS Scotland to recognise the importance of rurality, and that was another element that was raised in terms of that, its impact on cost of delivery in an area such as Perth and Kinross, and ensure that financial distribution methodologies properly reflect that. So that was something that was going to be addressed, and a request for the council leader to meet with and discuss with the First Minister and the Cabinet Secretary for Finance and Local Government. The second area is really just to, and I can provide further written information on this, is that there has been a directive from the Cabinet Secretary for Health and Social Care issued to NHS Scotland, or a new planning approach for NHS Scotland with a director's letter implementing a subnational planning cooperation and planning directions. And the directions place a statutory obligation on NHS boards to plan collaboratively across two subnational areas, which are East and West Scotland. It's a major shift in terms of how NHS Scotland plans its services from being centred around territorial boards to planning on a population-based regional approach, and is linked to the key priorities in the Health and Social Care, the Health and Social Care Service Renewal Framework and the Population Health Framework. So whilst that's in place, it does not change the role of the IJBs, and that was clearly set out in the letter, and that it doesn't change the statutory duties of IJBs. It changes the environment in which we're operating in terms of that engagement to think about beyond the health board and what might be required there in terms of that regional planning. So it's something to factor in our future thinking. And the third area is we had a very short timescale in which to reply to a letter from the Deputy Director of the National Care Service Development and Delivery Division in Scottish Government, seeking a perspective on voting rights for public partners, and to comment on the proposals by Scottish ministers. The letter was issued to the Chair and Vice Chair of the IJB, but we had, I think, 6 working days to respond to that. So it was not possible to do a consultation across our IJB membership, but we have, on behalf of the Chair and Vice Chair, responded positively to that letter, recognising the valuable contribution and participation and the lived experience in all aspects of the IJB of our public partners. And we were supportive of extending parity, but recognised that there were some key considerations that would need to be taken forward to enable that to happen. I think it's also worthy of note that Scottish Government team met with our public partners on Friday of last week, and by invitation, and gave our public partners an opportunity to speak directly with the Scottish Government team who are working on this to give their experience and perspectives as public partners on the IJB. So need to commend them for giving that time to our public partners and your time to them and your wisdom. So really good to see that that's taken place, and that I'm sure they valued your insights. And the last area I just want to commend to you before I hand over to Hamish and Sal is that back in just after the last IJB, we heard that our digital telecare team have received the Platinum Digital Telecare Implementation Award. And what that means is that our community alarms have been given the highest award in terms of the implementation and the successful completion of a transition to a fully digital telecare service, which is a significant milestone for us, but also I think is highlighting the amazing work that's taken place here in Perth and Kinross to achieve that, and how vital that is when we're in this winter period and our very vulnerable citizens who depend on community alarm systems. When the power goes down, they'll still be able to make contact and obtain vital assistance in those circumstances. So really to congratulate the team and commend that to you. And I'm just going to hand over to, I take it Hamish is getting his mic ready. So just to say a little bit about the test of change, because it sounds small, but I think it's really exciting work, and I'm really proud of the team for the work they've done to support this. So hand over to you.
Yep, slightly nervous about letting the cat out of the bag of this because it's not clear that it's entirely deliverable at the moment. But so back in the early winter planning stages, we were in consultation with our CUTE colleagues, as we are every week in terms of the planning for winter and right through the year. And there was a few bits that came together. The pressure on the ED departments is continuing to rise in Dundee and Perth and Kinross, well, right across Tayside. That's at odds with the rest of Scotland, where there's a plateauing or a following in a lot of ED departments. And we know that in Perth City and Dundee, that's where where this has been driven by. We're also very aware of the pressure on our GP colleagues, the rising demand, the frail elderly population, the budget constraints within primary care. So we've got these two issues that are going hand in hand. So we thought there was some monies being made available for winter planning. And so we put a proposal forward, which was really to essentially run another GP surgery over the late afternoon, early stage of midweek days, 4 hours, to provide GP first contact physio, perhaps pharmacy availability for GP practices or ED to book patients into on the day where their capacity, where the demand exceeds capacity. So that could be rediverting ED attendances, or it could be certain practices get full up, or they've got absences, so they're not able to provide for all the patients. We have very little data from what goes on in primary care, so we don't really know what goes on day to day across all of the practices in Perth and Kinross or Tayside. We've got very good data on what goes on in acute in terms of attendances, waiting times, etc. Sal's done a bit of work looking at whether the assumption is fair to make that because people can't access their GPs, then they go to ED. And certainly going through some case studies with that doesn't appear to be the case. It appears to be there's a perception that people can't get access to the GP practice, and therefore they just go to ED in the first place. So we want to try and unpick that, and part of what we're planning, which is a 3 or 4 month project over the probably the late part of the winter, if we can, is to manage to gather data from the practices, marry that up with the ED data, with admissions, etc., and to see how it works by having this additional capacity. Is it a good support to our primary care colleagues? Can we change the narrative around access? And does it take some of the pressure off ED as well? Because any pressures in ED reduce flow, the system gets clogged up, and we end up with more delays and more pressure in the system. So we're not predetermining what the outcome of it will be, but if you try and set up in a few short weeks, basically a new GP practice, it's very difficult. There's lots of things that we need to try and consider, lots of barriers. But Sal and the team are working through all the practicalities of it at the moment, and hopefully we'll be able to bring you some more positive news in terms of a start date, if indeed we can get it going, hopefully in the next couple of months. But Sal to add any more comments.
I don't think there's anything particularly to add. I think it's just very much we're aware that this has to be a safe service where the clinical governance goes round. So although we were quite optimistic they would start very quickly, I think we've all become aware that we need to make sure that this is a safe, not only for our patients, but also for the staff that work in there. So it may be a little bit later than we anticipated, but we'd much rather that it was safe and effective to enable us to do that properly.
Can I just come back very quickly? So perhaps Danny might want to comment. We've engaged right at the very beginning with our GP colleagues across Perth City. We're kind of focusing on that area initially this winter, hopefully, and it'll be very interesting to see. And I'll see Danny might wish to comment. There has been a call for proposals from Scottish Government in terms of walk-in centres, and these have been heralded nationally. I'm not going to get politically involved, but there's not much clinical support for a walk-in centre because it goes against everything that's been building up in primary care about just turn up on the doorstep and you'll get seen. What we've been building in primary care for years is you need to see the right person at the right time for what you present with. And if you phone up and it's actually a physiotherapist you need to see, or a pharmacist or a mental health officer or a counsellor, then that's the right thing to do. So rather than you deciding, actually, I want to see a GP and just turning up at the door. So this project that we're looking at failed to meet the requirements for getting funding from the Scottish Government for that because it wasn't a walk-in centre. Now, many walk-in centres down the south have an element of triage when you get to the front door. What we would be proposing is the triage happens slightly earlier with the GP practice or with ED, where that's our traditional model for care. That's our triage system, so it's just in case you conflate that with the walk-in centre approach. This is different. We think it's a better model than that, but we're not politicians.
Thank you, Hamish. Danny, any comments?
Just echo Hamish's comments there. I think we need to be careful that we don't send the wrong message to the public. It is about right care in the right place at the right time. So it's really important we don't confuse things by, starting new services that are sending out the wrong message. I think the challenge is going to be about getting some of the data. We want to know which patients are turning up at ED, potentially sometimes say inappropriately, but we can see why patients do sometimes. But it's which of those people would be better off served in a GP practice, I think, and looking at how we can support practices to manage those patients better, I think.
Thank you. Any questions? Sorry.
Hi, as Secondary Care representative, obviously this is welcomed work to us. We've been looking at the unscheduled work, and I think Jackie probably sees it at board every week. There's certainly a nice infographic that comes out now, and we know that ED is kind of our safety net for the whole of the NHS, isn't it? It's the one place that's there and people can just walk into. But again, if people are going there at the wrong time, then they're not seeing the right person in the right place to give that right care. So there are certain things that our ED clinicians, I don't think, would be upset with me saying this. They've got one set of skills that is very different to what our GP colleagues have. And actually, if it's mainly a GP problem, then, or a physio problem or a pharmacy problem, then actually they're not the right person to give that right care in the right place. And I think getting that messaging correct is important, because I think even as a clinician, and I think I know the health service in Tayside pretty well, it's sometimes still quite hard to navigate. So I think for the general public, it must be really, really challenging when they're unwell to know how to navigate the system and how to get that right care in the right place. So I think working with our comms teams and all of us working collaboratively around about that is the only way that we're going to, it's a wicked problem, isn't it? And how we're going to manage to try and get that right information out there. We do know that self-presentations to ED in the last month have accounted for between 80 and 90% of all attendances at our ED in Perth. So, that's a massive number of people turning up at the front door.
Thank you. I'll take Sandra's question first.
Thank you. Thank you, Hamish. That sounds like a really interesting and exciting piece of work. I just wanted to ask if the intention is to involve public partners in it.
Absolutely. Just need to get a bit further down the line.
We're at quite early stages, and we're probably being a bit over ambitious in terms of our timescales, but very happy to have input.
Thank you.
Great, thank you.
Thank you, Sandra. I'll go to Martin.
No, it's not based on that question. It's based on the report that Jackie gave and the direction letter that's come out to establish in the East and West. What is going to be the impact on the risk profile and the strategic planning for the IGB with the establishment that we'll be part of the East partnership, including Grampian and the Highlands. So there's going to be a change in risk profile and there's going to be a change in strategy. How will that impact? And have we been in discussion on it?
Thank you. Chief Officer.
I think, Martin, we might need a bit more time to work on that, actually. So it just came out in November, so yeah. I think we'd have to work that through because the letter is very clear about saying there's no change to the IGB's roles and responsibilities, but at the same time, the way in which the health boards are planning is changing. So we just need to work that through and come back on that. So I don't have an answer yet.
I will be asking that question at the board meeting tomorrow.
Thank you. Thank you, Martin. Heather.
Thanks very much, Hamish and Sal, for your update there. And I think I'm really supportive of this, and I hope the test of change gets, you can progress it, because I appreciate the governance issues and the safety issues. So I do hope it gets progressed. But I was interested in listening to the conversation there with Monica and with Daniel and yourself. And how many, do we track how many patients are directed to ED from 111? Is that tracked? Because I think that's that to me is an issue, that sometimes the patients are directed to ED and they don't need to go to ED, and it might be there's a better option. And I just wondered how that would factor into the whole out of hours transformation, because obviously that's quite a key, because that's what people will do. They will phone 111 and then perhaps be directed in the wrong way. And I just wondered how you were taking that into account.
Yeah, so it's all tracked. Since we've put in the flow navigation centre, so in December 2020, as part of COVID measures to try and prevent overcrowding in the ED, they put in this thing called flow navigation centres, and that is a consultant in ED on the phone taking calls. Quite often when 111 take the calls, if they're going to refer somebody to ED, what happens is they get a call back from an ED consultant, and there's a telephone triage or consultation or whatever you want that consult to look like. And some of that will be, oh my goodness, like, if you're really sick, 111 will tell you to go to ED, or they'll send an ambulance to take you to ED, right? That's going to happen. That's kind of an easy bit, isn't it? And there's other bit where actually you don't really fit the criteria for any of that. We'll do some supportive measures and you'll stay at home, or you might see your GP the next day. That's kind of easy as well. They're the kind of black and white bits. It's this grey bit in the middle that's quite difficult, and that's where most of the medicine falls into, isn't it? It's not really easy at either. The bits at either end are easy. But that bit in the middle, there's often a phone call from the consultant and ED to the individual patient at home. They happen quite quickly. They do measure all of that. I don't know, I don't manage ED anymore, so I don't know what the times are, but it used to be within an hour they would be phoned back by the ED consultant. And then there's a plan either, actually, you do sound pretty sick, and I think it's about a third of people who are asked to come up to ED. About another third will be given what's called a scheduled appointment. I liken it to Fast Pass in Disneyland, if you've ever been there. So instead of waiting in the waiting room in ED, you wait in your own house. So say you're phoning from Arbroath or you're phoning from Pitlochry, you've got what sounds like a broken wrist. They'll do a near me, they'll have a look at it, they'll get you to check that actually your fingers are still going pink, you've still got a pulse, tell you to take some paracetamol, and they'll tell you to come at 10 o'clock the next morning. And then you come at 10 AM the next morning and you get seen at 10 o'clock the next morning. So you do the waiting in your own house between 2 AM and 10 AM. But then when you come to ED, you get seen straight away. So that's called a scheduled appointment. And that's helping to schedule unscheduled care, if you like, rather than all those people sitting in the ED waiting room. And the other third of people are managed in another way. So it might be to go to pharmacy, it might be to see a physio, you know, whatever. So it's about a third in each place, depending on the outcome of that phone call. So that's really helped us to manage right care in the right place since December 2020.
Thank you. Heather, you want to come back?
That's it. I think that's really helpful, Monica. It helps me to understand. I was just reflecting on the out of hours, service and the test of change, and thinking, how will that fit into the model that you're describing? Because it's a different kind of model. So would the patient still be referred to the GP, and then the GP would refer to the centre that you're discussing? So if it was a 111, it would go to they would say go to your GP. They wouldn't say come to you first in the test of change project.
So we will be aiming for this to come directly from ED or from GP surgeries if they felt that they needed to use it. 111 is probably less used in hours for primary care GPs as such, but it is a big issue in obviously out of hours, because that's the way it's automatically accessed. And I know that 111 are part of the group that are discussing the out of hours reform, so they're definitely involved.
Thank you. I'll go to Hetty next.
Yeah, this is from the perspective of the general public. If they do not feel educated in how to manage their symptoms or where to go, they're simply told call 111 or given a basic instruction like that. It actually robs them of the opportunity, having that education, to make more educated decisions for themselves, which would be helpful in not having them all piling into ED and actually having them direct this more appropriately. And to that end, I think it would be very worthwhile involving public partners in the planning of this later on, when it comes to the type of signage and the way in which it is phrased and presented, given the fact that you're going to be looking at people with different kinds of neurodiverse conditions, mental health conditions, as well as physical disabilities, all of which could be an impairment to them being able to understand and interpret information given. Thanks.
Thank you. Chief Officer, did you want to respond? So,
I think you make a really, really good point there, Nettie, and you may not be able to see Dr. Peterson at the other side of the same end of the table, but she was nodding throughout what you were saying in terms of that opportunity to get that right would be a great one to take. Thanks. I'm speaking for you, Sal, but that's what it looks like you were saying.
No, absolutely. We're well aware of that. And we started the equality and diversity assessment really on in this process, and started by using some of the data that we'd already got within primary care to start the process and how it would work and that sort of thing. But we quite appreciate that we need further involvement. It's just at what point do we do that? And, we need the other things in place to then be able to get that engagement.
Hamish, did you want to come in?
Yeah, it was just, I guess I probably would be leaning to more a soft start. I mean, what we don't want to do is do the opposite of what you're describing and actually disempowering people by saying it's open doors and generating activity that otherwise would be self-managed at home. So almost by doing a slightly softer, less advertised initial start, we'd actually be able to see how it impacts on the status quo as it is at the moment. There was a visit from a sort of national group last week on the unscheduled care. That was a very busy 2 days for lots of people involved with unscheduled care right across Tayside. And one of the things that came out of it was about getting that voice for primary care rather than relying on Scottish Government public health messages to perhaps bring that back more locally to do the messaging and take some responsibility within Tayside. And certainly if we manage to progress this test of change and then implement it in the longer term, if that seemed appropriate, then we would absolutely want to be doing that at that point.
Thank you. Maureen.
Yes, I was trying to come in earlier, but going back to Sandra's point about were public partners going to be involved when you're, doing the planning of this. Public partners have already been told that they should really be involved in locality groups, and locality groups have been taking place for about 2 years, and we're still not getting an invite to attend. And at what stage do you think that public partners would be effective? Because I think they should be in at the beginning of some of the planning, like, rather than say, oh, well, we're not just ready for you yet, you can come in later.
Can I maybe just say something there? Because I think what we're hearing here is a description of a test of change that we need to pick up on, and there's been an opportunity arisen in terms of securing some funding to support that. So there's a time frame against it. So I think we need to allow that test of change to see. And you talked about a soft start, but it's really about testing it out. And then part of the evaluation of that and how you take that forward, I think that's at the point where we would be wanting to ensure we engage the right stakeholders around that, Maureen. That's what I would suggest.
Hamish?
Yeah, and sorry, just to quickly add to that, I mean, we will, part of the test of change will be to get patients' experiences of it. So patients who have come into that, who've gone to ED, etc., we want to make it come out of it the other end having a very good picture of what's gone over that 4 months.
Thank you. Any other questions on the Chief Officer's report? No. Oh, Lindsay?
Good afternoon. Yeah, it's just in regards to the representation. Obviously, with a test of change, I would have assumed that staff side are involved within that test of change. I know it's not me personally, but it's just assurances that within NHS Tayside staff governance standards are being adhered to, and that partnership representation from myself as the lead, Perth and Kinross, Angus and Dundee IGBs, that would be Raymond Marshall and Roman Komsky, are cited. And if that is... And with this moving forward, you will probably require staff side input in regards to staff governance standards.
Absolutely, but you'll be aware that I've already emailed you. I just have to apologise that just due to other pressures we haven't been able to meet, but I think I emailed you a few weeks ago and we've already met with HR just to get some further information.
I'm really sorry if I've not replied to your email then. I apologise for that.
That's fine, it's a busy time at the moment.
Thank you. Thank you, everyone. Any other questions on the report? No, can we note the report? Thank you. Thank you. 6.2, back to you, Chief Officer, for the Strategic Planning Group update.
Yes, thank you very much. I'm going to give a brief update and hand over to Nettie to say a few words. The last strategic planning group met on the 24th of November. It feels like it was a lifetime ago, but it was only about 3 weeks ago. We started the meeting with a review of the governance, the terms of reference, and with an update on proposals to take forward locality planning, as Maureen was referencing there. I think one of the things to note at that meeting, and I think this emerged from a a suggestion that Nettie brought to the group, which was to encourage members of the strategic planning group to bring a colleague or a partner, so extending the network around the agenda that we had on the 24th of November. So we had additional voices in the room that day, and we were looking at primarily mental health. The mental health model of care. We had a presentation on that and discussion on that, and how that is dovetailing and aligning with the new mental health strategy that's under development for Perth and Kinross in terms of that community strategy, and how it integrates with local services. And the key priorities for that strategy coming forward. So there was a bit of discussion on that. And then the start of an engagement around rehabilitation and reablement plans for older people's services. There was a high-level overview given of that, and really a request to set up a further session to do that justice, because that's about reconfiguring how we deliver rehabilitation and reablement across Perth and Kinross, and we know that that will be coming forward to the IJB in the probably late spring, maybe not in March, but I think it'll be the meeting after that. In terms of future proposals and options there. So the strategic planning group really wanted to spend some time on that. And those were the main items on the agenda, but I'm going to hand over to Nettie to say a few words.
Yes, it was just to say that I have been co-chair of the strategic planning for a year now, and my term in office is for being co-chair is now up. So it would really now be down to other members who are not normally participating, for example, other public partners or other participants, to be able to volunteer and come forward. Thank you.
Thank you. Thank you, Nettie. Any questions on the strategic update from anyone? No? Thank you. Thank you. Can we note the update, the verbal update? Yep. Thank you. Number 3, can I welcome Graham Binney, Independent Chair of the Child and Adult Protection Committees, and Ian Wilkie, Interagency Adult Protection Coordinator, and ask them to introduce the report, please. Thank you.
Thank you. I welcome the opportunity to present the report. I'm relatively new in post, so I wanted to come along and introduce myself. A lot of the credit is due to Ian, and I'll give him a thanks in this environment for all the work he does, not only on the report, but just around the adult support and protection agenda. So thank you, Ian. I'll let you cover some of the highlights from the report. I just wanted to acknowledge and give this group some reassurance about the strength of our connections across the public protection agenda, because this is just one area. We have strong connections with our police and health colleagues and with other public protection areas of business. Examples of that where we might want to try and find opportunities for efficiency or crossover areas are things like the exploitation of vulnerable people, which are not respecters of age. Children and adults come into that category, and perhaps transitioning of young people from children's to adult services. Just 2 examples by which we need to take advantage of all the skills that we've got in the wider metaphorical room. So thank you for the opportunity to present the report, and I will hand over to Ian to give you some of the highlights.
No, I'm not going to spend too much time. Yeah, there we go. So I'm not going to spend too much time going into the detail of the full report, and certainly the cover report that has been shared ahead of the meeting today. The kind of overarching kind of messages that we continue to use the Adult Sport Protection Act in line with what is our duty and our statutory responsibilities, and through a delegation from kind of council through to the IGB onto adult social work. And although there's always room for improvement, hopefully you feel assured from the contents of this annual report that we do that well, albeit we understand we still want to kind of make certain improvements in certain areas. Over the last wee while, particularly, I've been really keen on taking our work into some of the more ethically contentious areas around where our right to make choice becomes an inability to safeguard, and that is not an easy arena for our practitioners to navigate their way around. Ultimately, if we overuse the power and authority afforded us through the Act, and we overuse it, we run the risk of depriving liberty. If we underuse it, we negate our duty of care to adults. And this is an area that we're continuing to work in, particularly around issues around undue pressure and coercive control. And we're doing some work with Sarah Rogers' team around how we evidence that, particularly when we've got an application that needs to stand up in court. We're doing a lot of work around hoarding, and we're doing a lot of work around things like addiction and homelessness. So we are not sitting on our laurels. Hopefully you'll see from the report that we place a huge investment and commitment to self-evaluation and audit work, and certainly I've got a keen interest in myself in strengthening my own understanding about how we can better and triangulate our kind of self-evaluation and our audit work in a way that we currently don't. And hopefully you'll see again from the report that, so much so that we're completely plugged into a lot of the national work that's going on around the adult sport protection agenda, but also we've been invited to lead on some of that work because of that interest. And again, from the report, you'll have seen that I've been invited to take part in joint inspection activity of another area, particularly, and that has kind of led to that kind of strengthening and more confidence in our audit work that's led to kind of more kind of validated improvement areas. I'll probably just leave that there, but I'm happy to take any questions on the report. Thank you.
Thank you both. Any questions? Martin?
You briefly touched on the work you're doing in addiction and that. What are you actually doing? How many people is it impacting, and what's the results of it?
Yeah, no, I think that's a really good question. The challenge that we have around things like addiction and hoarding is changing a culture of understanding that actually it's not a lifestyle choice, and actually it's a trauma-informed approach you now need to take. And the more that we understand that, the kind of more we can then start to think about how do we change this approach, because it is a 180-degree flip for those who have always seen things like addiction as a choice, and hoarding as a lifestyle choice, to understanding the research that we've now been part of to say that actually this isn't a choice, this is someone's circumstances, and therefore we need to kind of flip this notion of kind of changing the way that we approach that. And once we do that, and once we are consistent in our approach to changing that complete way of thinking, then there's an opportunity there for us to engage in a way that we currently don't. If that answers your question, I think we're a long way away from it, I have to say, but I think that flipping that whole notion of it being seen as a choice is crucial to understanding how we change that way that we support those who do experience addiction or those who do experiencing hoarding.
That's music to my ears, believe me. And as having spent 34 years trying to get that understanding into the public arena, thank God somebody at least is now answering it.
Thank you. Any other questions? Danny?
Yeah, thanks, Ian. The report was very encouraging, I think. I noticed there's an increase in referrals, particularly from health, and that may be down to some of the additional training that you put on, which I think was really well received. How much of that increase do you think is due to better sort of case finding, and how much is it that there is actually increasing issues, I suppose, in society?
I'm not back on. I'm back on now. So we've always taken the view that we encourage all referrals from everyone, and actually gives us an opportunity to inquire. And in that inquiry, if there's nothing there, then we're confident that that's the approach that we take. So the increase in referrals from health has probably been twofold. One is we've been raising awareness, and you'll see from probably our communication, and I keep saying that I kind of feel like I've made it, because you can't walk past a bus stop now and you fail to see some kind of campaigning around adult protection, whether it's financial harm or sextortion, or actually just general awareness raising of this is what an adult at risk of harm could look like, and this is, if you see that, this is what you do. So that, alongside the work that our colleagues from NHS, particularly Grace Gilling's team, the public protection team, in supporting her health colleagues to not only recognise when an adult might be at risk of harm, but again, encouraging them and actually fulfilling their statutory responsibility to share these concerns with us, allows us to get in. So we are doing a lot of work around general awareness raising, and actually what constitutes an adult at risk of harm, and again encouraging, say, listen, if you're not sure, we're asking you to refer in and allow us to do what we need to do, and if there's nothing there, then that's fine, but if there is something there, let us get in really early, and the earlier that we get in, the greater chance that we can reduce or mitigate that risk.
Is literacy classed as adult protection, a need for adult protection? Because we a third of the population who have literacy problems. How do we engage with the people who have literacy problems?
Well, one of the best things, and probably the worst things, is the criteria for the Act itself is so ambiguous that arguably I could argue that most people meet it some of the time. So therefore, I would take the view that if someone had literacy problems and that led to a degree of vulnerability, then I could argue that the Act could apply. The other thing we've done in recent times is, again, change a culture of thinking where criteria can often be used to gatekeep resources. So we can use the criteria to rule people out. And what we've done more recently, and actually in the last few years particularly, is use the criteria to rule people in. And if you rule people in, and in ruling that person in, we've found through inquiry or whatever contact that we might have with that adult that there's actually no support need that might be required, then at least we can evidence that we've done that. But the one thing I would also say is I share data on our use of the Adult Support Protection Act, but everything that each and every one of us around this table today is doing is we've got a role and responsibility in adult supporting and adult protecting. So there's a lot more adult support and adult protecting that goes on than us having to use the Act to do that. We would only ever use the Act, and the other bit is we take a very much a human rights approach to how we use the Act. We would only ever use the Adult Support Protection Act if we couldn't achieve the same outcome if we didn't use it. So if we could support that adult who might require some support because of literacy, then we would always take the view as, well, we can provide that support anyway. If we need to use the Adult Support Protection Act to do it because we can't achieve the same outcome without using it, then let's use the Act to do that. So there's lots of people who in Perth and Kinross, in my view, will meet the 3-point criteria for the Adult Support Protection Act, but we don't need to use it because there's no value or benefit to using it because we can achieve the same outcome anyway. There's a lot of really good supports going in right now from each and every one of you that actually obviates the need for us to use the Act. The Act is there if we need it, but if we don't need to use it, we don't need to use it.
Thank you. Any other questions? Yes, Nettie?
Hi, I'm just wondering if you're working collaboratively with any other groups out there, you know, charities or other organisations that might be able to support what you're doing.
Absolutely. In the last number of years, particularly, we've seen one of our key improvement areas is to be more multi-agency. Now, it's easy to cite health and police as being one of our key partners, but actually in the recent times, we've been moving into some of the kind of communities kind of sectors. We did a session with our child protection colleagues up in Latham to ask the question, what does protection look like for you? We're doing a lot of work with the Perthshire Welfare Society, who support some kind of minority ethnic groups in Perth and Kinross. We've shared some of our literature and our guidance around adult protection and asked them, what does it mean to you? Because if it doesn't mean anything to you, then it doesn't apply to you. So we've been doing lots of work with lots of other people, really keen on embracing and strengthening our kind of user involvement. That's a key area for 2026 for me. We had a really powerful presentation at our Adult Protection Committee a few months ago from a young adult who'd been through both the Mental Health Act and the Adult Support Protection Act. So we're really keen on sharing what it is we do with those who use it. Again, I'm going to probably draw on my experience of my inspection work of another area, whereby they pose a very legitimate question around what's the value of what do you do and how do you know it? So that's the kind of where I'm going in 2026, is to really embrace that how do we know it question. So when I come back next year, I'll be in a better position to answer that.
Thank you. I was looking at the tables that we've got for the most at risk, and I was looking at the 16 to 24 years of age group. Although 9% is quite a small, amount, I was wondering, are these new risk cases, or are some of these carried on from childhood to adulthood?
Thank you, Sheila. Thank you very much for that. Again, that's a really interesting question, because we're doing a lot of work around, as Graham said, around that 16 to 24, probably 16 to 18-year-olds are really complex and cluttered and challenging arena for us, because there's been recent changes to legislation around child protection that raises the age of child protection legislation from 16 to 18. The Care and Justice Bill is coming over the hill, and that applies to 16 to 18-year-olds. The Adult Support Protection Act applies to 16 to applies from the age of 16. What we found in some of this work that we're doing, and give me an opportunity to invite you all to a conference that we're holding around this particular work and research we're doing next month. That's what we do know from the audit work is that where the 16 to 18-year-old is already known to social work, particularly kind of through kind of learning disability, there's a very established transition pathway there. For those who don't have a diagnosis of learning disability or autism, that transition pathway is not as coordinated as we would like it to be, and therefore that has got to be an improvement area. Where any new referral came in for 16 to 18-year-olds who are not already known to us or to social work, the data showed that actually there was not a lot of support required other than signposting that 16 to 18-year-old to what might be a more appropriate, and more often not, some sort of mental health input. But you're right, so getting our transitions right and that kind of screening for that 16 to 18-year-olds are a key priority for both the Child Protection Committee and the Adult Protection Committee in this next year. And again, we have commissioned research around that, and we are presenting that research at an in-person conference on the 21st of January next door, and you'll all be invited to come and take part and listen to that.
Thank you. Heather?
Thank you both very much for coming along. I really enjoyed reading this because I learned a lot from it and I thought it was really helpful. And one of the aspects that I thought was really interesting was the prevention work and the work that was particularly cited from the primary pupils in Letham Primary School, because the focus there was really about the harm that might be that they might suffer if they weren't aware of certain things. And I thought it was really interesting when you looked at the examples that they were very up to date and relevant with regards to technology and the harm that could be caused by technology and just by that engagement in technology. And I just wondered how much work goes on with primary schools and with education in general about that prevention aspect of the safeguarding work.
I could probably take that from, put my child protection hat on and say that a relative degree of confidence when you look at Perth and Kinross and Tayside in general, that's pretty good. We have safer schools apps that are used, just by way of one example, which are appropriately worded for different age of children, especially when you get into older children. We need to be open and honest about online threats and about exploitation in its various guises. And we see with online safety acts and VPNs and ability to get round the barriers, it's causing a lot of concern in making sure young people can negotiate these barriers and understand what the risks are. So I think I mean, I'm looking in, I don't know, my view from a child protection perspective is we're probably better with that of young people than adults. So that's probably the next link. That's maybe a bit of work that we need to think about, because adults can be exploited online equally readily as children can be. And the energy behind the child protection has probably nationally been greater than the adult protection side. So there's something in there that I need to learn from our child protection colleagues.
Yeah, I'm not going to add any more. It's one of these kind of things that where it highlights the importance of reaching out to people and saying what matters to you. And these young people have come back in very clearly telling us what matters to them. So therefore, that has always got to be a key priority. But adult support and protection cannot be seen in isolation. And Graham quite rightly said in his introduction that, we're strengthening our public protection approach. So therefore, we've got to be seeing protection through this kind of whole family approach. In order to protect the children, we need to protect the adults. We protect the adults, we protect the communities. So we really are kind of shifting away from the siloed working into a more generic public approach that we've not done before. But the other question I was going to say is about technology, and we've done some work with Abertay University, who are the leading sector around cyber security, and they do some phenomenal work with us around how we're all at incredible risk from artificial intelligence, and the work that they share with us blows your mind. And we cannot keep up, and they cannot keep up. But it just sets the tone of the challenge that we're all faced as we all move into a digital world more and more, and we leave this kind of in-person world behind. And whilst, as an adult, that I struggle with it, I mean, vulnerable, so I've got a degree of vulnerability. You can see how exposed you can be from some of that stuff, including children. But some of the work that's coming through Abertay just really blows your mind around the extent to which artificial intelligence is really, or could take over.
Thanks very much. I was really struck by the work that was being done in the children's arena that could be used for adult services as well for protection. And I just thought that from a technology point of view, that's really interesting, and how it can be converted to help make it a safer place for adults as well, particularly for vulnerable adults as well as children. I thought it was really relevant. And thank you for naming Abertay, as I've recently just stepped down from Abertay as Vice Chair, so I appreciate that. They do a lot of really good work, so thank you very much.
Thank you. I'm conscious of time. We'll take one last question, Nettie.
Yeah, it's just to say I found it was really interesting hearing what you had to say about the cybersecurity side of it. I have found personally that younger people tend to be much more switched on with IT, which is a good thing. However, even people sort of, sort of middle adult age onwards, some people really are very unsure about how to manage things with IT. And I do think there is a lot of value in all the work that you've been doing with the kids on this being a transferable thing for older adults and even middle-aged adults who are sometimes remarkably vulnerable to things. There's some of this level of sophistication is actually really quite stunning. For example, there's ones, are you a robot? Yeah, well, that's another one where people are being caught out. Thank you.
I'm going to get this right before I leave. Yeah, I completely agree with you, but just to give you a wee bit more assurance, we as in the trading standards team, I say we, it's actually not me, it's the trading standards team, are in current dialogue with a kind of central database from London who's currently tracking 24 hours a day, 7 days a week, online conversations with known scammers. And if that adult is in Perth and Kinross, they will reach out to trading standards in Perth and Kinross. And if trading standards think that they need to contact us to intervene and investigate, then we do that with them. Again, technology is always going to be one step ahead of us and one step ahead of them. But we're trying to keep up with. And the other bit is, if we need any help with IT, always go to the young people first, and they can help us.
Just to add on I agree wholeheartedly with what you said, but Ian's example can be slightly reactive sometimes. So it's how we get into that prevention space, because the tripartite approach to young people is the young people need to be kept by schools and their parents need to know as well, and that's the gap. But then you get into grandparents and an older demographic, that's a key issue, is how do you capture people? Because just doing it online isn't always going to be effective. So it's a very valuable question. It's something that'll be given some thought, I think, moving forward. Thank you.
Yep, thank you, Councillor McCall.
Thank you. I should just also declare I'm a lay member of the Adult Protection Committee, so that's probably why I asked no other questions. But I would like to urge everybody to understand that adult protection is everybody's responsibility, and that we talked earlier on about making it more aware, but it's not just through partner agencies, it's for individuals. And although we can do some work in the communities, if you ever see something that you think is an adult protection issue, no matter how delicate you think it might be, the helpline is completely confidential, and really encouraging people to use that, I think, will go a long way to help reduce any sort of stigma or perhaps even nip things in the bud. And that's the only point I would make. Nipping in there. I think it's an important point to make for everybody as individuals as well as the organisations you represent.
Thank you. Any other questions? No, can we note the report? Oh.
Your problem. Sorry, I can't see it from here. I just wondered if where are you based just now? Can people walk in if they want? And
other areas apply this, you need to submit a referral form, and we don't take that view. I mean, if you've got any concerns about any adults, you can walk in any place, you can go to contact any social work team. I would like to think you can contact health or your GP. If you've got concerns about any adult that you might be at risk of harm, then that we're confident will reach the right people in a way that allows us to do. And yeah, absolutely. As Councillor McCall quite rightly says, a lot of our public campaigning talks around where people can access the stuff on the website. We've got phone numbers on there. I'm not going to be one that proposes that we have this dedicated referral system. That can overcomplicate things and we can miss things. any which way that works for you works for me.
Thank you. One last point. I'm just going to pass over to the Chief Officer.
Yeah, I think that's a really important question that Maureen's asked, because I think it comes through in the data that what we're seeing are lots of concerns being raised, which is exactly where you would want to be, but much smaller people who are coming right through that system. But it's really important to catch people early. But the other thing, just to emphasise in terms of the availability of that, in terms of the wider network and where you can seek support and help or express concerns, it's also available 24/7, 365. And when we talk about the services that we offer, that comes through out of our social work team. So, and we have trained mental health officers in that team as well. So, just to make a wee plug for that, and recognising that those people will be working right through Christmas 24/7, 365. Thanks.
Thank you. Thank you, Chief Officer. Can we note the recommendations in the report? Agree the recommendations? Yep. Thank you. Thank you, gentlemen. I'll now move on to the Tayside Lead Partners Services Annual Report. Jane?
Thank you. Yeah, so this is the annual paper providing an overview of all lead partner services across Tayside. You'll be aware within the integration scheme, this is where a service has been delegated to one of the health and social care partnerships who have responsibility to plan and deliver on behalf of us all. So the aim of this paper every 12 months is to ensure that all three health and social care partnerships have sufficient transparency, oversight and governance with regards to these services. As you'll be aware, public dental services, prisoner healthcare and podiatry are services that sit within Perth and Kinross. I am aware that there is a huge amount of information in this report. There's a number of colleagues present today who may be able to assist given the breadth of services covered. But in the event we're not able to answer your questions today, I'm very happy to provide them following the meeting. Thank you.
Thank you, Jane. Any questions on the report? Martin?
Sadly, this is a situation that we see across Scotland at the moment. There's been an exponential demand in services for an assessment for autism. And this has been presented to services that are already under extreme pressure. There are efforts being taken both across Tayside in terms of establishing a pathway that will assist individuals and will improve our response. And there's also work underway within Perth and Kinross to find more efficient ways of increasing the number of assessments that can take place. But yes, this is a real challenge. It's not what we want to see, but we're taking steps to move the situation forward.
Thank you. Any other questions for Jane? Yes, Sheila?
Just a quick question, Jane. I'm looking at item 2.1 in the report in the table, and where does primary care services sit in this?
Currently, according to the scheme of integration, the primary care services manages the contracts, and that's a department of NHS Tayside. Strategic coordination of the local strategic plans is coordinated by Angus at IGB. So operationally, primary care within our area sits with our primary care team in Perth and Kinross. But there is, I think we might be discussing that in the development session on Friday.
That's fine, thank you.
Thank you. Any other questions for Jane? No, thank you. Can we note the recommendations in the report? Thank you. We're now going to take a 10-minute break, so we'll come back at 22. Thank you. Next on the agenda is Finance and Audit, and we'll start with Donna Mitchell, Chief Finance Officer, to introduce the report.
Thank you, Chair. This report is the third financial update for 25-26, and it sets out the projected financial position as at month 7, alongside an update on the progress with the financial recovery plan. Based on expenditure to the end of October, we are projecting a year-end overspend of just under 4.6 million. And after applying the remaining general reserves, this reduces to just over 4.4 million, which is around 1.6% of the total budget. And whilst this does remain a significant and a concerning pressure, it does represent an improvement compared to the last projection reported. The most significant pressure remains within social care. This accounts for just over 4.1 million of the overspend, or 4.1% of the social care budget. This is largely driven by high-cost packages and increased demand within older people's and adult services. And these areas are continuing to experience high demand for care at home and complex care packages. Our health services are projecting a smaller overspend of 247,000, and this is around 0.1% of the health budget. The pressures remain mainly within our inpatient settings, and this is reflecting the patient acuity, the vacancies, and the use of supplementary staffing. This is being partially offset by an underspend within prescribing, and that's due to lower than budgeted price and volume growth. I would warn, though, that that position does remain subject to change as the year progresses and is highlighted as a specific risk within the report. The forecast also includes an update on the delivery of recurrent savings, and as part of this year's budget, the IGB approved savings of just over 2.4 million for 25-26. And it is now assumed that around 91% of these savings, so around 2.2 million, will be delivered within the year. Financial recovery actions agreed under Part A of the recovery plan, which was considered at the last IGB, these are now reflected in the forecast position. And these actions, alongside other in-year movements, are expected to deliver just over a £1.1 million reduction in projected expenditure. And that exceeds the original target of 950,000. Some actions remain challenging, particularly those linked to reducing supplementary staffing. But overall, delivery is expected to meet the agreed targets. Part B of the recovery plan, which focuses on more strategic and higher impact options, is the subject of a separate report on today's agenda. Since the last meeting, a report on the financial position and demographic challenges within social care has been presented to Perth and Kinross Council, and the Council has approved up to £4,180,000 of additional funding from its general fund, and that's to help meet the current level of demand and to support the continued delivery and scoping of the recovery actions. Discussions with both Council and NHST side are ongoing as part of routine financial oversight. Looking ahead and planning for the 26-27 budget and the following 2 years, it's taking place in significant uncertainty and continued financial pressure across the system. Early indications are presenting a substantial funding gap, and without additional funding, the options being developed through Part B of the Financial Recovery Plan will be key considerations to addressing the sustainability of services in future years. And COSLA, they do share these same concerns. They have issued a warning about the growing crisis in social care. They've emphasised that social care funding must be clear and focused national priority. COSLA's 2026 manifesto seeks an additional £750 million of investment in social care, and they've highlighted that without urgent action and fair sustainable funding, the viability of essential services is at risk, mirroring the situation we find ourselves. A budget development session is scheduled for all IGB members on the 16th of January, which I very much hope everyone can join us. And that's for us to consider the implications of the Scottish budget, which is due to be announced earlier that week. Finally, I would highlight that this forecast is based on the first 7 months of the financial year. And demand levels, workforce pressures and cost assumptions do continue to fluctuate, and the overall financial risk remains very high, and we will continue to monitor the position closely. And while progress has been made on financial recovery actions and additional support has been secured, the financial position remains under considerable pressure, and strategic decisions will be required to ensure long-term stability. Happy to take any questions.
Thank you, Donna. Any questions from anyone? No. If there are no further questions, can we agree the recommendations in the report? Yep. Thank you. Next on the agenda is the financial recovery update. Can I pass to Chief Officer, please, to introduce the report?
Thank you very much, Chair. This report provides the Integration Joint Board with a brief update on the work undertaken to take forward potential financial recovery actions associated with Part B of the IJB's Financial Recovery Plan as authorised on the 8th of October. This report begins to clarify the respective decision-making responsibilities of the Integration Joint Board and Perth and Kinross Council and NHS Tayside in relation to the financial recovery actions. You'll recall that at the meeting, and as Donna has outlined, I was asked to request an increase in funding to achieve in-year balance, and a report was presented to Perth and Kinross Council on the 29th of October, which agreed additional allocation of up to £4.18 million within the financial year to meet existing costs associated with high service demand and to complete the work outlined in Parts A and B of the Financial Recovery Plan. The Council also noted the IGB's direction to scope out the actions set out in Part B of the Recovery Plan and acknowledged that this required substantial work to assess in full the impact should these actions be implemented, and also acknowledged the requirement for extensive consultation. So the Council agreed to receive an update on progress at its meeting, which is due to be held on the 14th of January, and agreed to seek additional funding to address the demographic financial budget pressures confronting the local authority area through next year's local government settlement. And as I mentioned earlier, the Council also took a decision to declare a health and social care emergency at its meeting on the 10th of December. So we have, as a health and social care partnership team, been working along with others to begin to scope Part B of the Financial Recovery Plan for all of the 5 actions. We've obtained legal advice as decisions around the implementation of this are likely to require approval by Perth and Kinross Council in some respects relating particularly to operational policy, criterion and practice, which will rest with the Council. No recommendations are made to the IJB at this stage, and the outcomes of the initial assessment will be considered as part of the budget setting process for 26-27. Happy to take any questions, thanks.
Thank you. Any questions for the Chief Officer on her report? Yes, Councillor McCall.
Thank you, Jackie, for that. You mentioned that there's some decision making that maybe do have to be done or made referred to Perth and Kinross Council. Does the same apply to the Health Board?
In this instance, if we're looking at the recovery actions in Part B, they primarily relate to social care and the social care pressures. So in terms of the decision making there, that's why I've emphasised Perth and Kinross Council, but it's the wider impact that we would need to be assessing in terms of bringing that forward too.
Can I ask a supplementary then? So can we get some assurance that when we are assessing those, notwithstanding that perhaps the driving cost is coming from social care support, that a large number of the people that we do support have more complex needs than that and have a health component as well, and that any consideration given to the categories and the Plan B take a much more holistic view of the whole system, or the the whole environment that people live in, and the support that they need across the board, and that we're not potentially making savings, robbing Peter to pay Paul, to coin a phrase. Can I get that assurance, please?
I'm happy to give you that assurance, Councillor Nicole. I think it's really important that we recognise the situation that we're in and the gravity of that, and that the importance of working across the two partners, as in Perth and Kinross Council on the NHST side, and the Integration Joint Board, and that we've never been in this territory before, and that's why it's so difficult. And we're only going to be able to work our way through this if we're working together, and that everybody's sighted on the issues, sighted on the detail, and see the part that they have to play in that.
Thank you. Any other questions? Oh.
Thank you. The question I've been asked about IJB finances is, given that it's got a £300 million revenue, are there more efficiency savings out there?
Thank you, and that's a very appropriate question to ask. In our assessment as finance officers, we have been through the budgets for both health and social care numerous times and looked for efficiencies across the board. And wherever we see something that has a higher unit cost, if you like, than what would be determined to be best value, we challenge that and identify that and bring that forward to the IGB to ask them to put that onto a potential saving as part of their financial strategy. It would be correct to say there absolutely will be more efficiencies to make. They often need capacity to deliver them, to find them, and to make sure that they are fully realised. But from our assessment, we would advise that the efficiencies that could still be made are not material in value, and unfortunately would not go towards making a big enough dent in the funding gap that we are currently seeing and that we predict for next year and the following years. I would underpin that assessment with the reference that's been made in both the council report that was in the 29th of October, and also conversations we've had as an IGB before, and that Perth and Kinross is the 29th out of 32 lowest social care expenditure across Scotland, and that's based on the local financial returns of 23-24, and we're waiting for the updated figures to come through. But that's our baseline position to start from, to start trying to find efficiencies from. So in our assessment, yes, there will be, and it wouldn't be prudent for any area to say there aren't more efficiencies to find, but our assessment is they are not material or material enough.
Thank you. Yep, please.
And can you give some examples of the efficiency savings that you've already achieved?
Yes, and you put me on the spot, but we have written reports about this before. So what I could do is I could forward that to IGB members. As you know, the strategy for this IGB is the financial strategy comes in three segments, three core components. The first is around efficiency and making sure that we are looking at efficiency first, and that's the first thing we look at when we're trying to fund our pressures. The second is there a change? Is there an improvement that we can make in that service? Is there a transformation that can be realised? And the third and final, and only if they too have been as exhausted as we can, do we therefore look at prioritisation of services and look to making cuts. So the majority of our £14 million of savings have been approved by this IGB since 2022, and as per this report, just short of that 14 million are actually going to be delivered. And the vast majority of that sit in the efficiency segment. So we have, as an IGB, been very successful in delivering recurring efficiency savings from an already fairly stretched budget. But I will forward that around so that everyone has that.
Thank you, Donna. Dave.
Just one comment and a question. The comment is that Scottish Care issued a press release for the 3 key asks of the Scottish budget. The first one was stand united with COSLA and the call for the £750 million to social care. So that goes in line with what Don was saying about the partnership's position and COSLA's. The question is, you were mentioning consultation, Jackie. Will the Commission services be involved in that? And I'm wondering the merits of putting out a statement or a position statement to them in the new year. Thanks.
I think one of the things that we've focused on here is doing a high level assessment at this point in time, and the report that will come forward in January to the council will be seeking a direction, if you like, in terms of the direction of travel there. I think we wanted to be very careful about having sufficient detail behind that to be able to inform and support the appropriate decision making, if you like, in direction that we require, without causing distress and alarm that's perhaps unnecessary. But you'll know that within this that there are a number of areas where services that we commission would be likely to be affected. So absolutely they would have to be involved, and they would have to be involved in full consultation, and that would be an absolute essential to be able to carry that through, Dave. So I can give you assurance that that will happen.
Thank you, Martin.
Partly answered my question. That was the question I was going to ask, to be involved when it knows what they have to be involved in at an early stage. And also the efficiency, we're just under 14 million that we've saved. That's a tremendous effort by all involved in creating that condition, and that has to be noted as well.
Just to say thanks for that comment, but one of the things that we would bring forward to the budget development session is a sense of the timelines that we would be working to on this, because it's actually a really significant piece of work that we're sitting here when you look at it in its totality.
Thank you, Chief Officer. We've got one question online from Sandra.
Thank you very much. I just wonder if, with the seriousness and severity of the situation, if it isn't a false economy not to be involving a health economist to support the work moving forward. Thank you.
Thank you, Chief Officer.
I think it's something that we should give consideration to, Sandra, but perhaps because that would be something we would want to be thinking about in terms of that longer term perspective and view, and be able to link that into the public health issues that arise from anything that we might take here. But I think there's also something about engaging a wider range of partners around how we can do things fundamentally very differently across the community. I think that's what that's the territory it's going to take us into, which might mean that we would do less of some things, but it would have to go somewhere else. And so therefore how we support our third sector partners, our commission services, to do things differently as well is also quite ambitious, and something that I think we would need some external support to be able to take us into that territory. Yeah.
Thank you. Bernie.
Sorry, my question is in relation to the Scottish Government's policy statement on the right to breaks for carers and the financial implications this would possibly add to the council and the impact of that on unpaid carers.
Thank you. Jackie Donna.
Maybe just clarify the question there, Bernie. Is it about additional policy decisions that you're concerned about how that would be realised?
yeah, so we're looking at already an overspend and part B of obviously having to look at where you're going to make cuts. And I'm just thinking that the Scottish Government's policy statement on you know, rights to breaks for carers could have an additional impact, you know, financially. So where that fits and the, you know, at the end of the day, it's the impact of that on unpaid carers, because it will be their expectation. So thank you.
Yeah, really just to say, absolutely, Bernie, and that the assessment that would have to accompany any decision making around this is going to have to be very thorough, comprehensive and robust, and unpaid carers would have to feature within that, along with a whole range of other people who would be negatively impacted. So really just to give, it's not an answer to your question, but really to say it would be a serious consideration for the IGB.
Nettie?
Thank you. When I was talking about a holistic approach, I was including everything, not just the services that are offered, but you know, family members and you know, the wider network that people have around about them, because they inevitably pick up the slack. Thank you, and thanks for the question, Bernie.
My question is around the services that are currently provided externally who do receive funding from the council to marry up support workers with those who require them in the community. And if there is going to be a substantial reconsideration of how the limited budget is allocated, this will obviously impact grants and other financial support that would go to these organisations. In event that that happens, some of these organisations would no longer be able to function or function effectively, which will then leave people in a vulnerable situation without the ability to be able to marry up themselves and the support workers that they need. And I'm wondering how the council might be willing to address that.
Chief Officer?
I think that is an area that's is an area that we'd have to consider all of that in the round. And when we're looking at these actions in Part B, they are actually pretty, I think I described it in the report as undesirable and unpalatable. And so that what that will mean, if we have to take any of these actions forward, is that there will be a negative impact somewhere. And I think one of the things we have to really consider is if we're looking at measures across the five areas that are mentioned here, if we are saying that we can no longer provide for everyone who's receiving a service now, what would that mean in terms of there also being a reduction in service across our commission services in the voluntary sector and those that we have service level agreements with? Because that would, it's the cumulative impact of that is going to be quite significant.
I think where my concerns lie is that in event that the services are impacted substantially in some way, that it could lead to an increase of demand on the NHS for looking for support, not because the people themselves are necessarily really requiring those services, but because they have no place else to go for the essential help that they need. I'm thinking, for example, there are many different examples, but one example might be someone requiring assistance with, say, washing and dressing or going shopping or, you know, day-to-day management, cooking meals at home. And if that service that marries up the person requiring that service and the person able to provide it, if that interface goes, how will that be managed because of the impact that it would have further down the line? Thank you.
Just to say, we'd have to factor all of that in, because this is a very general paper at this point in time, and we'd have to look at and have to examine a lot of this in detail. But I think what you're raising in a number of the questions is the interrelatedness of a change in one part of this across the whole piece and what that means and the unintended consequences, which is why there's going to be quite a bit of work to actually take forward to bring forward the level of detail and the information that decision makers will have to have in front of them.
Heather.
Thanks very much. Just a follow-up, and you've already said it yourself there, Jackie, but I think it's important, the initial scoping, we've got a list of what's been included in the initial scoping, and I think as we move forward and we get further information here, it's going to be really important that we include assurance in the documentation that we're meeting our statutory and legal requirements as we go forward to make decisions, because it's I understand that there's already been some legal advice sought, but I think it would be really important to be clear on the legal advice and the decisions that we're taking. And the other point you've just made it was we have to think about the unintended consequences, because whatever decision we make will have another impact on another part of the system in some way. So we really need to take that into account and look at the whole picture rather than just the bits that we're concerned with. Thank you.
Thank you, Chief Officer.
And I think, Heather, that's a really important point, and that our legal advisors to the IJB have supported the preparation of this report. They're aware of the work that we've done so far and are engaged in being able to provide that advice to me and to the IJB and ultimately to the council as well. But there was a second point and I've lost it. I've lost my train of thought. It might come back. I'm sorry.
Thank you. If there are no further questions on this, can we note the recommendations in the report? Thank you. Next on the agenda is an update from the Audit and Performance Committee. Can I ask Councillor Sheila McColl to provide her update?
I'll have to come back to the committee. I don't have one with me today. Send something out in writing. I just didn't bring with me. Sorry.
Thank you. Moving on next on the agenda, 7.4 Tayside IJB Risk Management Strategy. Can I ask Donna Mitchell, Chief Finance Officer, to introduce the report?
Thank you, Chair. And I'm going to be introducing both this report and the next report, but I would like to give thanks to Phil Gerard, our Risk and Governance Manager, on his work that has taken this forward for us as an IJB, in particular on the Tayside Risk Management strategy. This report on the risk management strategy seeks the IJB's approval of the refreshed and updated Tayside risk management strategy, which is included in Appendix 1. The Tayside risk management strategy serves as the overarching framework for managing risk across the IJBs, with our previous strategy last reviewed in 2021. And its purpose is to ensure a consistent collaborative approach to risk management throughout the Tayside IJBs. And this update has been developed in partnership with NHS Tayside, the 3 health and social care partnerships and the local authorities. You'll be aware that Perth and Kinross IJB also has its own risk management framework, and that was approved just in February this year. And that approach, that already supports this approach. So it's underpinned by that. The IJB is requested to approve the updated Tayside strategy as the overarching framework for risk management across the Tayside IJBs, and it's asked to agree that the revised strategy will be reviewed every 2 years or sooner if necessary. Thank you.
Martin.
I refer to my previous question about East and West and the impact that the East may have on the risk that may pose to the IJB. So if it's going to be 2 years from now, it might be too long. And once they've actually unravelled what they're supposed to be doing, then we'll see how that may affect the risk appetite that we've got.
I would say, as Jackie mentioned earlier, we don't know enough at this stage, but the approval to review every 2 years or sooner if necessary would give us that cover.
Thank you. Any other questions on this report? No. Is the board happy to agree the recommendations in the report? Yep. Thank you. Donna, back to you for the directions annual summary, please.
Sure, I'll be very brief. So this report provides a summary of the current directions that have been issued by the IJB to Perth and Kinross Council and to NHS Tayside. Members will be aware that directions are legally binding instructions under the Public Bodies Act of 2014, and they set out a framework for operational delivery, delegated functions, financial resources, and the responsibilities between the Health Board and the local authority. So directions remain in place until varied, revoked or replaced. There are 16 directions set out in Appendix 1 to this report. 4 of these directions have been issued during 2025, and 12 of the 16 directions are marked at a green status and therefore on track to deliver, and 4 marked as complete due to being closed or superseded. Through regular monitoring and reporting, the IJB is being assured on the implementation of the directions and its compliance with the Scottish Government's statutory guidance. Happy to take questions.
Thank you, Donna. Any questions on this item from board members? No. Are we happy to agree the recommendations in the report? Yep. Thank you. We're now on to number 8, the Health and Social Care Chief Officer. Can I ask Pauline Johnson, People and Culture Manager, to introduce the report, please?
Thank you. So this report is to replace the Chief Officer because Jackie Pepper is now retiring. And this is a joint recruitment process between the NHS and Perth and Kinross Council. What the committee has been asked to agree is to delegate authority for shortlisting of candidates to the 2 chief executives and the 2 named people culture leads from either NHS Tayside and Perth and Kinross Council, and seeks agreement that those 4 individuals will be given delegated authority to actually deselect any candidates after the assessment centre process. And then the final candidates that go through for final interview will be based on the appointment from this committee, which will be asking for 2 voting members from NHS, 2 voting members from Perth and Kinross, and 1 public partner, which was the precedent that we set in Perth and Kinross partnership in 2022 when we did the advert for Jackie at that time. And that's what we're seeking agreement of. Within the appendix, you will see the timeline and the proposed selection process that jointly has been created between NHS and Perth and Kinross Council as being the set out process that we would apply in the selection process. That's it.
Thank you. Any questions on this paper? Councillor Illingworth?
Yeah. How would you reduce the risk of unconscious biases in this process?
In terms of the appointments process, anybody that's been identified as being on the final interview selection panel, we can deliver training on unconscious bias as we would normally to any appointments committee. We would be expecting the candidates or the panel, to have been on training, and we can deliver training individually if that's what anybody's been appointed to be on the panel requires on this instance, so that's not an issue.
Thank you. Any other questions? Maureen?
So all public partners then get will public partners get a request to nominate someone to go on the panel?
That's what the ask is of the committee today. So I'm asking to know who the 2 voting NHS, who the 2 voting PKC and who the public partner would be. There is an assessment centre that would be conducted and led by NHS Tayside. And again, there might be an opportunity for other members. It wouldn't be the full remaining board from the IGB to be involved, but they could also be involved in that arrangement, which is going to be held at Ninewells Hospital as laid out in the appendix. Okay.
Thank you. I'll go to the question online from Thomas, please.
Yeah, thank you, Chair. Mine was just a brief comment just about the importance of us getting that decision from the IJB as quickly as we possibly can. We've teed up between Pauline and her counterpart in NHS Tayside the hope of getting this advertised by the end of this week, so that we get that out there and extending that recruitment period until January. So if the IGB is able to make that decision today, then that would be incredibly helpful just for allowing us to get the process moving.
Thank you, Thomas. Just for context, I did send an email out via Nikki, I think it was, asking for expressions of interest. So if there are no further comments, can I ask that we agree the recommendations in the report, and for myself, Martin Black, who put himself forward, Sandra Alders. Sorry, Nettie. Thank you. Pauline, can I revert to you if there's an absolute deadline?
We would ideally want to see who would be on that in advance when we invite candidates. So the deadline that we've proposed for candidates expressing an interest in the post is Sunday the 18th of January. So if we know who is on that, we would then be able to advise candidates who's on the panel, what the process will be when we invite them to participate. So there is a wee bit of time that you could discuss that.
Thank you. I'm conscious that other people did put themselves forward. Can we agree the voting members in that case from NHS Tayside and Perth Council, Perth Kinross Council? So that would be myself, Vice Chair, Martin Black, and Councillor Frampton, if people are happy with that recommendation. Yep, thank you. And we'll hear back about the public partner in due course. Thank you. Yep.
Whoever is on the panel needs to be available week beginning the 23rd of February. So please don't put yourself forward if you're not available any of those days that week. Okay, thank you.
Thank you. Thank you, Pauline. Next on the agenda are the items for information. The Local Child Poverty Action Report 2024-2025 and Local Action Poverty Action Plan 25-26, NHS Tayside Winter Resilience Plan 2025-2026, and the IJB Work Plan 2025. 9.4 is future meeting dates for approval. Does the board agree the proposed dates for meetings through 2026? Yep, thank you. That brings us to the end of the public business on today's agenda. Due to the potential identification of a small number of individuals, the remaining item of business will be considered in a private session. Members attending online, please now leave this call and join the private meeting invite. Thank you.